about 2020, I mean epidemiological information. And in 2020, it is described as the 5th most usual cancer type in the human population. But from 1 minute, listen. From the point of the view of mortality, it is in the 4th, 3rd places, after the lung cancers and breast cancers. 3rd, 4th position, it is passed together with the prostatical cancers. Let's say from the point of view of incidence, it is less usual than prostatical. You know, prostatical it is 3rd one, yeah? But from the mortality, it is equal or little bit even more. Incidence of this problem, it is approximately 7-8 persons in 200,000. Mainly, sit down in my place and you will change the slides. Sit down in my place. 1 minute, listen me, please. This has some, we can say, race and geographical, some determination. For example, from all countries, the most incidence we see in Japan and in South Asian countries. And little after then I will introduce your risk factors, you will understand why especially this. About the race of the pupils, African and Native Americans. Yes. Approximately twice more usual than for European or Asian peoples. Remember about it, please. About gender, twice more usual for some literature even say 3-4 times more usual. Again, according to the countries. For example, in European statistical information, it showed 2.5 times more usual for the males. About the age, 50 and older. More than 80% of the persons with the gastric cancers, it is old persons. Very seldom you can see it for the young persons, guys. Remember about it, please. Now change the slide, please. Right, please, the etiological factors of the formation of the cancer. As you know, guys, that is the genetical mutations. Right, please. All genetical mutations can be divided into 2 main groups, hereditary and acquired forms of the genetical mutation. Let's start from hereditary type. I want to remind you about CDH1, which is located in 16 chromosome, in the long arm of the 16 chromosome. By the way, it is absolutely ununderstandable till now the mechanism of connection of mutation of this gene with formation of the gastric cancer. But incidences show that approximately in 30-35% of persons of gastric cancer, we find the mutation of this gene. Again, without explanation. What is the function of this gene? Who will say it? CDH1. 2 types of the proteins it is produced. Right, please. First one, it is cadaurin. Sit down, please. Cadaurin. Second one, it is the G factor, G tissue factor. Cadaurin and G tissue factor. G tissue factor is responsible for necrotization of the tumor cells. Let's say somehow we can say that this is oncosuppressor effect gene because it is responsible for necrotization. But exactly mechanism of connection of this gene mutation and formation of the gastric cancer is why especially gastric, yeah? If it is the factor which is responsible for necrotization of the cancer cells, why it doesn't give formation of another locus tumors? Why especially it gives the formation of the gastric tumors, yeah? Till now it is, sit down here. Till now it is Anand and put on your white coat. The humanity must to know the heroes, yeah? They say sit down in front of us to show your face for everything. Okay, let's continue. This is, right please, also the PT53, we primarily we speak about it, yeah? CPA1, it is located in 17 chromosome, CPA1. And it is also, guys, you know, this is the situation that we don't see exact connection between formation of the tumor and the mutation of the, but we know that this is presented. We know that the persons with the mutations of these genes has more possibility of formation of tumors. But to say you now pathogenesis will be very hard for you, because till now this pathogenesis is not discrete. Right, please, acquired type of the mutations, mainly connected right and market with chronic irritation of the mucous membrane of the stomach. That is the type of the acquired mutations and risk factors which is forms these mutations, yeah? Guys, remember forever, any chronic irritation of, let's not say mucous membrane, let's say to epithelium. Any chronic irritation of epithelium can give formation of hyperplasia. Any hyperplasia, it is pre-oncogeneous situations, pre-cancerogenous situations. Hyperplasia, it is active growing and formation of multi-layering structures, yeah, like the leukoplakia, which we described before in oral cavity. If there are chronic irritation of the mucous membrane, right, please, number one, of course, Helicobacter pylori. Helicobacter pylori, which has approximately 22, 23 pathogenetical factors, exotoxins, the ferments which is decrease the acid level, which is make exactly the damaging of the mucous membrane. Why? Because it must to pass to the submucous layer, yeah? It is live inside of submucous. Because inside of submucous we don't have high acid level, yeah? Yeah, it is live in acid environment, but it doesn't live in the acid environment, really. That's why remember, please, Helicobacter pylori, it is aggressively factor which is irritated the mucous membrane. Approximately 70% of patients with gastric cancer associated with Helicobacter pylori. Dietary factors. N-nitroso, I don't know, do you listen about N-nitroso? You know, N-nitroso today, guys, in the China, in the some South Asian countries, is used like the salt. Like the salt. Samely glutamate natrium, which is increase the taste of the food. All these factors, which nitroso is used for conservation of the food. Mainly conservation of fish. So, friends, 1 minute, understand. That is very important. Today in some countries use the cancerogens in the food. Then you buy something from that countries which is productive, there are big chance to have inside of it such kind of the dietary factors, which is critically irritated the mucous membrane, which has oncogenical some responses to the cells of the stomach. Why especially stomach epithelial cells, mucous membrane? Actively growing structures. You know, your epithelium absolutely changed during 1 day. All your gastrointestinal tract epithelium changed during 1 day. You know that your fats is in 40%, it is epithelium. In another 45%, it is the bacteria. Only in 20%, it is the food. I think it is necessary to know, guys, epithelium, it is make the big part of the fats. If there are active growth, of course we can have the damaging proliferation of the cells with onco problems, which can be happening in the future. Right, please. Next point. Tobacco smoking and alcohol abuse. Tobacco smoking and alcohol abuse. Very important risk factors. Especially, I want to attract your attention into smoking, not into alcohol. By the way, I don't find any investigation which is exactly show the influence of alcohol in the formation of stomach cancers. All the problems associated with the biliary system. Because you know alcohol is mainly toxic for the liver. That's a mainly first problem which is originated, it is, for example, cirrhosis. And because of the cirrhosis, we can see different formation of the problems and gastric, but not primary influence exactly. You know, it is very interesting. Alcohol, it is very aggressive liquid, but God knows why. It doesn't so much irritate the mucous membrane of the stomach. It's hard to say for me now. Why? Because till now we don't have necessary investigation about it. But about tobacco smoking, absolutely another picture, guys. Absolutely, but approximately twice more usual for smoking persons. And you know how it is described. During the smoking, some amount of this smoke goes to your digestive tract through the esophagus. Not all of it goes to the respiratory system. It can go exactly, look, it is not the influence of these metabolites from the blood, but it is exact influence into the mucous membrane of the digestive system. That's why, much more usually smokers have esophageal cancers, not the stomach cancer. The more upper is, for example, laryngeal, pharyngeal, then only esophageal, and only finally gastric cancers incidence can be increased. But anyhow, there are today investigation which is absolutely surely show that 2 times more usual smoking persons have the cancer comparable with non-smoking. Now you understand, let's see near of her. Now you understand why it is male problems. Not because genetically it is connected with Y chromosome, but because these behavior problems which I described for you, alcohol abuse, smoking, till now is more usual for the males. And that's why this kind of the problem is much more persistent in the male population comparable with female. Now right, please, very interesting factors which we call family factors. And usually you think that if there are family, it means genetical. No, guys. Family and genetical can be same, but can be different. For example, some dietary specificities in some families. So you should understand, sometimes we see really in different generation of one family, we have some kind of the problem. For example, bronchial asthma. Or but then we look to the situation, we see this is the families which is, for example, work in the agricultural some spheres and have the animals. Or this is the families which is make some specific work, professional. Or this is families which have some dietary specificities. That's why you must understand, guys. That's why, right, please, approximately 10% of the persons have family type of cancer. And only 1-3% from these family cancers, it is really inherited forms. 1-3%. Here I write. Next one, Fred. Anyhow, you will find in the future. Continue, please. Several infections. For example, Epstein-Barr. Epstein-Barr, guys, it is damage any glandular tissues. It can be your salivary gland, it can be your gastrointestinal glands, it can be your pancreatic glands. That's a glandular tissue, it is the target for the Epstein. What else? Papillomatous virus. Papillomatous virus, it is the polyps of the stomach mucous membrane. Approximately, guys, in 10 up to 15% of the cases, they can give the cancerization, formation of the cancers, scars of the stomach mucous membrane, which is usually because of the ulcer disease. Yeah, just the scar, guys. It gives the hyperproliferation of the connective tissue and also can be the reason of formation of the cancers. Remember about it. I find in the literature traumatical forms of the gastric cancer, and mainly it is described after car accidents. If there are chronic traumatization, 2-3 times, for example, the person have driver, during the car accident, guys, the wheel usually damage the proper epigastral region and the inferior portion of the thorax. That's why if it is chronically, can be repeated several, not once. That's why this is usually the problem of professional sporting drivers, for example. Many times of the trauma can give formation of microhematomas in the layer of the stomach, which is also during the time proliferated by connective tissue, and in the future can give formation of such kind of the problems up to the formation of the cancers. Of course, mainly not the cancers, but the sclerotization of the stomach is happened, but sometimes we can see formation of cancers also. That is main risk factors. Change please the slides.
drugs also have them.
Drugs, yes. Drugs, you know, it is not necessary to mention now everything. All the factors which is irritating mucous membrane. So everything which is irritating mucous membrane and chronically irritated. For example, even if you drink every day non-steroidal anti-inflammatory, it can be cause not only of ulcer disease. By the way, why not? Let's speak about ulcer disease. You know, ulcer disease has 5 complications, and one from them is malnutrition. That's why we can say, guys, that ulcer disease, it is one of the risk factors. Ryan, listen. Ulcer disease, okay, thank you very much, you are very kind. Ulcer disease, it is one of the most important risk factors for formation of the cancer. Why? Hyperirritation, chronic inflammation of the mucous membrane. All right, please, classification. We have 2 types of the classification. First one, according to the macro picture of the cancer, according to macro picture of the cancer.
And from the risk factors, it said that...
Friends, up to next day morning, we can speak about risk factors. All and others you can find in the books. Yeah, I don't have so much time. What about you want to say?
Actually, like people with group A positive.
It is connected with blood group. Yeah, blood group A. Again, till now it is not explained anyhow. You friends, you know what the problem, guys. Any information which is not proved scientifically, which is not shown. For example, till now we don't have connection with CDH1 gene. We understand, yeah, we find that the persons with the gastric cancer have the mutations of this. But sorry, maybe, who knows, me or you have this mutation or not. We don't make genetical investigation. We don't know. Maybe if we will make screening tests of these genes, we will find that the half of the population have this kind of the mutation. And what? It doesn't mean that this, or now group, blood group associated with formation of the, what is the connection? What is the mechanism of this? This is very hard. Maybe mainly investigated the persons with this risk group because they can have more usual, for example, ulcer disease. Or I don't know to say. That's it, to say now that it is proved, I write it here, yeah, that really group A, today we see that approximately in 10-15% more usually registered the gastric ulcer. But how? What the mechanism of this registration? Nobody cannot explain it. By the way, samely today the group of the blood connected with allergical problems, with some infectional disease. For example, it is shown that autoimmune type of the allergical reaction is more usual for B group. This kind of, but what is the mechanism of this? It is just only statistically shown information in small group of investigation, very small groups. Continue, please. Now, first one, it is the Borman classification according to macroscopical, endoscopical picture of the cancers. Right, please. According to the by the way, very old classification, approximately 100-year-old classification, but till now we use it. Right, according to the Borman, there are 4 types of gastric cancer, 4 types. 3 types, it is by minus tissue, 1 type with plus tissue. That's why 1 type, it is hyperplasia, 4 types, it is hypotrophia. That's why 1 minute book, please here. First type, it is hyperplasia. In place of the tumor, you can see aggressive growth of the tissue. Another 3 types, vice versa. And the last one, it is limited plastica, then we have diffuse spreading. But anyhow, they will look attentively to the region of the cancer, we see a little bit depression. Another 2 types, it is formation of so-called niche effect. What is the niche effect? Author which describe it. Then you give, for example, the barium swallow and make X-ray. You see the depression in the X-ray picture. Yeah, it is specific mainly for ulcer, because in case of ulcer there are defects of the bone. But it is also specific for these type of the tumors with formation of the depressions. As I remember, please, second classification is more new, and during this classification, it is pathological, by the way, classification, not histological form, but the main pathological structural specificities. All cancers can be divided, stomach cancers, into two groups. First one, it is intestinal. Otherwise, we call it local form of the gastric cancers. Second one, it is diffuse forms. What is the intestinal forms? Right, open the brackets and write, please. Number one, localization of cancer in some part of the stomach. Mainly, we describe by topographical localization 5 zones of the stomach. Little after I will introduce, you know, anatomical portions of the stomach. Yeah, that's according to the position of the intestinal type of the tumor. Why intestinal, guys? Because it is inside of some portion of intestine. Intestine, we mean gastrointestinal tract. Diffuse because it is spread through the whole wall of the stomach. And what is important, guys? In case of intestinal forms, we see that males twice more usually have than females. In case of diffuse, vice versa. Much more usually, we see formation of the gastric diffuse cancers. You remember, like we speak about the Hirschsprung disease. Then we speak about the long segment forms or total aganglios. We say it is the female's problem. Then we speak about short segment forms. We say it is male problem. Again, to explain for you why I can know. And what is important, diffuse form, mainly it is inherited form of the cancers. And Lifraumelli here, it is necessary to mention because majority of this patient has the P53 gene mutations, yeah? So we fix it. For intestinal, vice versa, in majority, I write here, yeah, that we can find on this P53, APC, yeah, which I say you before, even HD1, but in majority of cases, no any genetical base. It is absolutely acquired form. For the intestinal one, right, please, majority, 99% of metastasis, 99% of metastasis, it is hematogenous. For diffuse variant, 99% of metastasis, it is lymphogenous. Remember about it, that is very important. After we will speak. In case of intestinal one, huge association with Helicobacter pylori. Majority of the cases, we see that these persons have the association with. In case of diffuse, no association. So remember about it. There are the big differences, yeah, between the first and between the second type. Change, please, the slide. Now, write, please, histological types. Histological types. What is interesting, guys? Of course, if it is epithelial type of the tissue, we see the adenoma. But adenomas we don't see in the stomach. Benign tumors of the stomach, it is very seldom, very rare. It is very, by the way, in case of the lungs also, we have approximately same. Benign tumors is very seldom. And in stomach, same way. Instead of adenomas, we see just adenocarcinomas. That's why remember, please, the main histological form, it is adenocarcinoma, approximately 90% of all the cases. 90% of all the cases. And it can be formed by two main types, which I say you before. Intestinal, then it is local, and diffuse, then it is spread through the all epithelial layers of the mucous membrane, mucous coating. Yeah, I put in the next slides the histological. No, don't change now. After I will show for you histological picture. Nothing unusual, guys. You can see the gland. They have the round form, and they surround it with atypical cells. Yeah, roundly located. Between them, we have stromal elements. We have the muscularis mucosa, which is cover the mucous membrane, proper muscular, all muscular layer of the mucous membrane. Yeah, you know. We have muscularis propria and we have muscularis mucosa. Yeah, that's it. You see normal tissues, but inside of the normal tissues, round glands, which is surrounded with atypical cells. This is classical picture of adenocarcinoma. Second most usual type, it is lymphomas. Lymphomas. In majority of the cases, guys, this is secondary tumors. That is not the primary tumors, which is originated in the stomach. It is secondary metastatic tumors. Third third most usual form, it is sarcomas, or we can say stromal form of the tumors, which is originated from connective tissue. Primary tumors, which is originated from stomach, very rare, very seldom, guys. I don't know, am I writing here? Approximately you can write up to 2%, maximum 3% of all tumors. That's a seldom form of the tumors. Next one, it is carcinoid tumors. Carcinoid tumors, it is like the odd cell tumor of lungs, small cell tumors of the lung. It is acute tumors, guys. Acute tumors, as you remember, mainly located in the region of the pylorus. Yeah, that is the part of the stomach glands, which is called productive gastric. Yeah, that's why here we can see formation of acute type of the tumors. Again, then we will speak about clinical signs and symptoms. We will speak again about endocrinological signs. Yeah, as we see in case of the anatomical location. Right, please. 5 main locations for the gastric cancers. First one we call the cardiac location. On the brackets right, please, mainly it is not the cardia, but it is distal portion of the esophagus. Investigation is shown it can be growing to the cardia, but primarily it is originated not in the side of the cardia, but it is descended from esophagus. Second part, it is the small curvature, approximately 3-4 centimeters below the cardial aperture. In the greater curvature, it has 2 locations. Left upper one along the gastroleonal ligament, on the level of gastroleonal ligament, and lower one on the level of the gastrocolic ligament. And finally, fifth one, it is pyloric. Pyloric localization. By the way, it is approximately 60% of all anatomical forms of the stomach cancer. Pyloric localization. Remember about it. Change the slides, please. Now, right, please. Staging. And you know what is interesting, guys? T gradation here absolutely differs from T gradation of all another tumors. As you remember, for all another tumors, T show the size. Here, T show the level of invasion. Level of invasion. Because I don't remember everything, let's change the place. No, you go here, I will read here for you, because all these mentions to remember is impossible, but you need to know it. Let's say, right, please, the grades T. Of course, I don't speak about T0, Tx, it is stupid. Right, please, T0 here, by the way, again, difference from the lung cancers. As you remember, for lung and breast cancer, then we say T0, it also means the cancer in situ. Here, no. Cancer in situ doesn't include it in T0. As you can see, it is the different gradation. T is cancer in situ. Let's say T0, it means no cancer. You make investigation, you don't find anything. Let's say if there are cancer in situ, you write T is. Right, please, T1. That is the level of 2 layers, guys. Mucous membrane, muscularis mucosa, and submucous mucous membrane. That's it. This is 2 first layers, mucus and submucous layers. Right, please, T2. I will not speak now about gradations. Gradations we will after. Now let's speak about main classifications. T2. Right, please. Up to muscularis propria. That's a third big layer of the wall. It is muscular layer involved in the tumors. Yeah, tumor is reached to the muscular layer. Right, please, T3. It is mainly, guys, tumor which is passed up to subserous layer. But usually in the level of T3, serous membrane and neighboring structures is not involved inside of the tumor. Yeah, tumor is come to subserous layer. Maximum, it is damage the serous membrane, but it doesn't give the invasion into the neighboring structures. Otherwise, we can say it doesn't go outside of the stomach wall. That's why it is located inside of the stomach. It doesn't spread it outside. Bless you. Finally, fourth layer, it is the contactogenous invasion. That's a tumor is go out from the stomach wall and it is entering into the peritoneal cavity. Now, what will be happen after? It is hard to say. Maybe will be penetration to the neighboring organs. Maybe it will be spreaded by the peritoneal liquid. That's a different possibilities can be happening. But remember, then we say T4, it means tumor goes outside from the stomach wall. And gradation, also little bit different, and especially I want to say that M gradation is developed by the Japanese methods. Japanese classification, guys, it is according to the metastasis into the lymphatic nodes. Little after I will show it for you. Now write please, for us, N0 again I say you, we understand, we have no lymphatic nodes. N1, I write here 1, 2 regional lymphatic nodes, but it is necessary to understand that not all regional lymphatic nodes. One minute, look to me. For example, in this staging, it's not exactly shown. But in the Japanese, why I like the Japanese classification? Because it is show lymphatic spreading according to location of the tumor. For example, if the tumor located in pyloric region, N1 it means it will go to the supra and infrapyloric lymphatic nodes, but not into supracardial lymphatic nodes. Let's say, this is important. Let's say, for example, in staging, it doesn't attract your attention into the, it is written, it is passing to two groups of lymphatic nodes. But which group? Which is located near of location of the cancer. Which is located near of location of the cancer. Exception, it is diffuse cancers. Only in case of diffuse cancer, we don't matter into which group of lymphatic nodes it's spread. It is important to 1, 2 lymphatic nodes. Why? Because diffuse it is spread forever. We don't have anatomical localization of the cancer. You understand what the problem? That's it. Generally, remember please, in the future, if you will work in the clinical practice, you will need it. Then we say N1, it means for intestinal form of the cancer, 2 group of, maximum 2, can be 1. 2 group of lymphatic nodes, which is located just near of the cancer location. In case of diffuse one, doesn't matter which. Doesn't matter which, but open the brackets and write please. Only lymphatic nodes which is located along of greater and lesser curvatures. Because we have regional lymphatic nodes which is far from greater and lesser curvatures, which I will describe you little after. Write please, gradation N2. From 3 up to 6 group of lymphatic nodes. Otherwise, you can write that all lymphatic nodes, which is located along the greater and lesser curvatures, involve in these regional metastases. Finally, N3. Generally, we say, guys, far lymphatic metastasis. It means we have involving not only, we can say, intraligamental lymphatic nodes. Why intraligamental? Because that is the lymphatic nodes along the greater curvature, lesser curvature, which is located inside of the greater omentum and lesser omentum. Yeah, primary parts, which is attached to the stomach. But in case of N3, we see the spreading of the metastasis into far lymphatic nodes. For example, celiac group of the lymphatic nodes, aortal group of the lymphatic nodes, superior mesenteric group, inferior mesenteric group, pancreatic group, splenic group. Let's say this is the lymphatic nodes. They belong to the regional lymphatic nodes of the stomach because they collected lymph, but they doesn't locate it just in the neighboring of the stomach inside of its ligament. Such a, or otherwise, it is passing to absolutely far lymphatic nodes, like supraclavicular, infraclavicular, retroperitoneal group of the lymphatic nodes. Let's say N3, it is far metastasis, but only lymphatic metastasis. Okay? As you remember, I told you before that mainly lymphatic metastasis pass by diffuse form of the gastric cancer. Intestinal form of gastric, from that point of the view, intestinal form is less better. Because if, you know what is the problem, guys? Lymphatic nodes try to localize it your cancer, your patient cancer. They try to stop it. They try to kill it. Unfortunately, in majority of the cases, it is impossible. But this is the function of the lymph. What is the function of the lymph? Protection. Lymphatic nodes make the protection. That's it. Then lymphogenous metastasis we have. The score of the spreading of metastasis is not so high. Any lymphatic node will try to stop it. Let's say from surgical point of the view, it's hard for me to say what is better, how I can say metastasis is better. But just from the point of view of treatment, of result of treatments, lymphatic metastasis treated better than hematogenous metastasis. I think it is understandable for you. Hematogenous metastasis, it is the rapid speed. For example, from the stomach up to one of the main places, brain. Stomach metastasis, hematogenous metastasis, much more usually pass into three places, which you know very well. It is the lungs, it is the brain, it is the bones. And what to do after this if the brain metastasis is happening? You understand that effectiveness of your treatment will be not so big. Otherwise, you will do, for example, if it is lymphatical metastasis, you will do, for example, D3 gastrectomy with neighboring lymph. What is D3? I will explain you after. With neighboring lymphatic nodes, and you will reach the good effect in case of lymphatic metastasis, but not in case of the hematogenous. It's like in your mind, you must understand that not all metastases equal to each other. About the great M, everything is safe to do.